Hi, everyone. So could everyone take your seat? We're about to start. So I wanted to start with an apology. So there's a junior staff strike, so Geula couldn't be here. There's also simultaneously a conference going on, so Professor Shorek couldn't be here. So I'm your guest lecturer. Let me introduce myself without them. My name is Dr. Neda Zak. I work for a nonprofit organization called Prize for Life. We focus on accelerating the development of treatments for ALS. And really what I wanted to talk to you about, sort of like as a last lecture for this course, is a different perspective from what you had so far in this course, and that trying to look at different diseases from a drug development perspective. So if your goal is to really develop a treatment for a disease, how do you go about doing that? So Prize for Life. Prize for Life is a nonprofit. We are based in Israel and in the United States, and our mission is to accelerate the development of treatments and a cure for ALS. What is ALS? So I think you heard about it a little bit in this course. ALS, amyotrophic lateral sclerosis, in the United States, Lou Gehrig disease, in Europe, motor neuron disease. Same disease, different names. It's a neurodegenerative disease that specifically affects the muscle, the motor neurons activating the muscles. As the motor neurons activating the muscles die, we see a progressive weakness leading to progressive paralysis, progressing all over the body, and leading to death. The disease is 100% fatal and rapidly progressing. So death usually occurs within 3 to 5 years. The two most famous examples of ALS patients really highlight another aspect of this disease, and that's its heterogeneity. So one of the most famous patients is Lou Gehrig, who was a baseball player. And he was young and very athletic, of course. Still, he lived with ALS for less than 2 years before he died. The second, or maybe by now, the most famous ALS patient is Stephen Hawking, the British physicist. And he has been living with ALS for over 50 years now. And somewhere in this range lies all of the ALS patients in the world. So that tells you already something about the disease, and that's that it's very heterogeneous. This is something that you see in all neurodegenerative disease, and this is something that we want to understand because we want to solve. So kind of more facts about ALS. So as I said, ALS is 100% lethal, and it's lethal very fast. So usually it kills within 3 to 5 years from symptom onset. And that creates a situation in which there are very few patients alive at any given moment. So in the United States, there are about 30,000 ALS patients. In Israel, there's about 800, which puts the prevalence of the disease at about 1 in 10,000. So at any given moment, 1 of 10,000 patients is living with ALS. However, the probability of contracting ALS is about 1 in 1,000. So 1 in 1,000 people living today will die of ALS. What is the why is this difference between 1 in 1,000 and 1 in 10,000? Yeah.
It means there's a high chance of getting it, but you don't have a large pool of people actually having it at the same time.
Exactly, but why? Why is that? Yeah, because of the very short disease profile. So at every given moment, there are very few, but overall, there are actually quite many. So the official numbers are 1 in 1,000. They're actually growing. So now it seems that they might be more accurate to say 1 in 500. So what is the manifestation of the disease? So the disease can start in so the disease affects the motor neurons. The motor neurons activate the muscles for voluntary movement. So the only actions that are affected are voluntary movement, but there's any clear progression profile. So the disease can start at any part of the body. And so in about 80% of the cases, it starts in the limbs. So that's the most common. So it could be any one of the 4 limbs. And in the rest of the 20%, it starts in the mouth area, what is called bulbar onset. So that would be difficulties in swallowing or in speech. There's no clear, as I said, there's no clear profile, but what we see as the first symptoms is weakness, less ability to create very fine movements, and then that leads to more generalized weakness and paralysis. And with this paralysis, we also see muscle atrophy. So although the disease affects the neurons activating the muscles, once the muscles are not activated anymore, they atrophy and they also die. Then the disease progresses from one body part to another. Again, there's no clear profile, so it can progress between the limbs or between the mouth and a limb and so on. And eventually, the thing that would lead to the patient death is almost always respiratory failure. So the inability to move the chest muscles enough to maintain respiratory volume enough for breathing. So this is kind of what a clinician would see. The very obvious symptoms that a pathologist would see is that the motor neurons die. So the process goes that you see abnormality in the motor neurons while they are still alive. And I'm going to talk a little bit about this abnormality. Then this abnormality leads to the degradation of the connection between the neuron and the muscle. So this is an axon connecting the cell body to the synapse with the muscle. This axon starts to retract, and then the connection to the muscle is lost. The next stage, the cell body that already had symptoms of disease dies, and then the muscle also atrophies due to lack of activation. Now, if you want to understand the mechanism of a disease, and you really you start at nothing. So let's say you're a clinician and you start to see patients with ALS and you want to investigate that. What would be the easiest thing? So you don't have any, right? You don't have a lab. You're just a clinician, but you want to understand the disease further. What would be something that you could do relatively easily to characterize the disease better, to understand it better? What would you do? Okay, so you want to have a very good clinical profile of them, right? That's why you tell them to move around. Yeah. Anything else? Yeah? Yeah.
You will look for mutations in the genetic code, no?
Then this is true, but I would go one step prior to that. First, you would try to see if the symptoms that they experience are also shown in the family, if there is any heritability for this disease or for any of the symptoms in it. And if you find this, you find any sort of familial aspect of the disease, then it's easier to look for a mutation, because then you can compare the affected family members to the non-affected family members. Whereas if the patient is an individual patient, it's very hard to identify which mutation could be relevant, right? So, and indeed, one of the first things that, let's say you characterize a new disorder, one of the first things that you would see is try to identify the heritability of the disease. And ALS, in this case, is really a case study for most diseases or most complex genetic disorders. In that case, that most patients don't have any obvious clinical profile in the family. That these are called sporadic patients. So sporadic meaning that the disease occurs sporadically within society. And then about 5 to 10% of the patients appear to have a familial case. Familial case meaning that there's an obvious increase in probability within the family. This is not an easy definition, because what you call obvious is not always easy to measure. So the obvious cases would be cases that really follow a Mendelian distribution. So let's say half of the family members have ALS, or a quarter of the family members, depending on the type of mutation. But what if you see that in large families, the percentage of people with ALS is more than 1 in 1,000, but it still is pretty low. So that's a difficult definition, what's familial. And if you go by the very strict definition, there's about 5%, and if you go by the very loose definition, there's about 20%. Also, then you look at these patients and you try to characterize the mutation in them. And like many diseases, what you see is that there's not one mutation. So different families have different mutations. There have already been about 40 mutations identified for ALS. So this problem, what does it mean if you see the same disorder in people with different mutations? What could it tell you about the disease?
Could be several diseases that
So-
we characterize as one.
Well, so the clinical manifestation is how we call something a disease. So it still is one disease in that sense, but it might be very different biologically. Or it could be that these mutations affect the same pathway, right? So the question would be, how do these mutations relate to each other? Or maybe they don't relate, so how do they converge into the same clinical manifestation? And these are questions that we ask for all diseases. There's nothing specific about ALS. And because of this complexity, ALS doesn't really have a treatment. So there is one treatment approved for use today that is called riluzole. On average, it extends survival by 2 to 3 months. So it's not a very effective treatment, and it has not so mild adverse effects on the patient. So not all patients choose to use it. And effectively, a lot of people in the field would say that there really is no treatment for ALS.
How come Hawkins survived so much?
This is a very good question. There's no answer to that. So one thing that is notable is that in the early 80s, Stephen Hawking had tracheostomy, meaning the insertion of a breathing tube. So he doesn't breathe independently anymore. Not all patients undergo tracheostomy, so this is a matter of personal choice. And a lot of people refer to the point of tracheostomy as like death or tracheostomy for a patient, because this is really the point where the patient is unable to breathe alone and may or may not get tracheostomy due to choice or chance. So in that sense, like according to that, you would say that Stephen Hawking only survived with the disease until the early 80s, which would still make him a tremendously long surviving patient. And also the amount of time that he survived with tracheostomy is one of the highest recorded ever. Yeah.
Do they check his genetic code or use it and take his mutations versus
Yeah.
other mutations?
So-
Is he agreeing to participate in
So
this?
first of all, I would say that Stephen Hawking participated in several trials. Stephen Hawking is a sporadic patient. He doesn't have ALS in his family, and he doesn't have any known identified mutation. Okay, so challenges for developing treatment for ALS. So there's no treatment on the market right now. There aren't that many patients alive at any given moment, which is a difficulty from two perspectives. Once, it makes it very hard to check a potential treatment because it's hard to find patients to recruit for a clinical trial. And it's not easy to develop it because there aren't a lot of consumers for a potential treatment at any given moment. So then if you want to develop a treatment, you need more research, you need more patients, and you need better clinical trials. And this is exactly the type of topics that I want to talk about today. So I'll get into them in more detail. And before that, I wanted to I felt that I have due diligence to present kind of our perspective, or Price for Life perspective. So Price for Life was established by Avi Kramer, who you can see here. So when he was diagnosed with ALS, this is here, Avi was 29. He was a first-year MBA student at Harvard Business School. And it's really like he just moved to Boston, and he was planning to take over the business world. And he was diagnosed with a disease that has 3 to 5 years mortality and doesn't have any treatment. So kind of his way to deal with that, physically and emotionally, was to start Price for Life, start a nonprofit. It would utilize all of his capacities and network to accelerate the development of treatment. And the way he chose to do it is through a prize model, and that's why it's called Prize for Life. So the prize model is a model in which you define a challenge and you invite people to submit solutions for this challenge, and the best solution wins a prize. And the idea behind it is that really to do this very strategic thinking to define what are the barriers for developing a treatment for ALS, and around each one of these barriers to develop a prize program to someone who would be able to remove this barrier. And I'm going to show you a small video about Avi, if I'll be able to. I hope so. Wait. So it's in Hebrew. Let me find another video. I'm sorry for the short delay. So there are people who don't understand Hebrew in the audience, right? If they are, please nod your head. Are there non-Hebrew speaker in the audience? Absolutely nobody is nodding. So shall I show a video in Hebrew? Okay, thank you. So this was a while ago. Yeah.
גג העולם, בוגר מחשבים מהטכניון, ראש פרויקט בחברת אבני שבדיוק התחיל את לימודי התואר שלי באוניברסיטת הרווארד. אלא שאז הוא הבחין שהאצבעות שלו נחלשות ופתאום היה קשה להחזיק כוס קפה או לאחוז מעיפרון, והרופאים בישרו לו שהוא לוקה ב-ALS, שזו מחלה ניוונית איומה וחשוכת מרפא שבה כל המערכות הגופניות משתתקות אחת אחרי השנייה בתהליך שהוא איטי אבל בלתי ניתן לעצירה. אלא שאביחי החליט שהוא לא מתכונן לוותר בלי קרב, שהוא חייב למצוא תרופה שתילחם בגוף שלו שיחזיב. והוא גייס את חבריו למסלול מנהל העסקים בהרווארד, הקים עמותה, גייס $מיליוני ושיגע את כל הממסד הרפואי כדי שיתחיל במחקר רציני. בינתיים המחלה המשיכה להתפשט בגופו, ואביחי מנהל היום את חייו ואת העמותה שלו באמצעות האישונים בלבד. השבוע הוא קיבל את פרס ראש הממשלה ליזמות וחדשנות, ושום עין לא נותרה יבשה. כתבתה של סמדר פלט.
לקבל מראש הממשלה פרס על יזמות. הוא חולה במחלת ניוון שרירים, ALS, משותק כמעט לגמרי, לא מסוגל לדבר. הנקודה שעל המצח היא עכבר המקלדת שלו, בתנועות עיניים וראש. אביחי כותב בעזרתה את מה שהוא לא מסוגל לומר. לפני כן, ב-2005, הכל נראה כל כך מבטיח. אבחי סיים את הטכניון בהצטיינות, עמד להתחתן עם החברה שלו, שאמורה הייתה להצטרף אליו להרווארד. שם התחיל לימודי תואר שני במנהל עסקים.
כשבאתי לפה פעם ראשונה, מה שנכנסתי לחדר הזה, אני זוכר שרציתי להוריד את הנעליים מרוב יראת כבוד, יראת חרדת קודש ממש. הייתי רגע בעולם, ועדיין לא ידעתי שאני חולה, למרות שהסימפטומים התחילו. ואחרי חודשיים קיבלתי את ההבחנה, ומגיא בעולם נפלתי לבור הכי עמוק שאפשר לדמיין.
זה התחיל ביד רועדת, אחר כך לא הצליח להרים אותה. באותם ימים קרא את יומן המחלה של חולי ה-ALS רונן פורט, והבין מיד.
והוא פשוט אמר לי, זה מה שיש לי. ואז נכנסתי אני ליומן, והיה ברור מה העתיד טומן בחובו, שזה פשוט נורא, שהולך להיות נורא, ושכל יום הוא היום הכי טוב בחייו. אולי בחיינו בעצם.
ALS זה בעצם סוג הגרוע יותר של ניוון שרירים. זה משהו גרוע ביותר כי הוא הורג מאוד מהר, תוך 3 שנים. וכי ברגע ההבחנה הוא מומצא. וכי אין לו תרופה. פה העצה היחידה זה תכין צבא.
ואני חושב שלקח לו באמת שלא יותר מ-36 שעות של הסתגרות, ומאותו רגע הוא לא הפסיק לנסות ולהבין יותר לעומק מה זאת המחלה הזאת. לנו לא יודעים שום דבר על המחלה הזאת, ומה צריך לעשות כדי לגשר את הפער במה שיודעים היום ומה שצריך לדעת כדי להגיע לתרופה.
מהר מאוד הוא מבין שבגלל שיש מעט מאוד חולי ALS בעולם, 1 מכל 10,000, חברות התרופות לא משקיעות כספים במחקר, זה לא כדאי להן כלכלית. בתוך זמן קצר הוא מצליח לצרף למשימת מציאת התרופה סטודנטים באוניברסיטה וחברים מן הארץ.
ומה שזה אומר זה שאני צוחק כי כנראה שזה הבוס הכי קשה שהיה לי. הוא יודע למה אני צוחק. ואחד הדברים שהוא עושה אולי הכי טוב, נורא קשה לתת במחמאות, אבל אחד הדברים שהוא עושה הכי טוב זה להצליח לגייס אנשים ולרתום אותם לטובת משהו שאחרת לא הייתה להם שום ידיעה בו.
אביחי מנצל את הידע שכבר רכש בלימודי התואר ובונה תוכנית עסקית. הוא מציג אותה בפני כל מי שמוכן להקשיב לו.
אז בואו נראה כמה זה בכסף. 120 חולים, אנחנו נשלם בין 10,000 ל-15,000 דולר לשנה. זו חברה ראשונה שנמצא טיפול אפקטיבי ל-ALS, וזה יהיה בלוקבאסטר אדיר.
שנתיים עוברות, אביחי עומד לסיים את התואר השני בהרווארד. הקבוצה שהתגבשה סביבו מתחילה לגייס כספים למימון המחקר. לאביחי כבר קשה מאוד לדבר וללכת.
First goal is to work in the graduation ceremony. Walk with my own feet.
שהוא באמת מאמין שאולי עוד יקרה משהו. ואני קצת פחות. המחלה היא פרוגרסיבית, היא מתקדמת. היא לא עוצרת לרגע, היא לא מרחמת. ואני ככה רוצה לבלוע כמה שיותר שעות בילוי איתו. ואני נורא חוששת מהרגע שאני אתגעגע לזה. אבל אני מנסה לא לחשוב על זה.
בשנים האחרונות, מאז שאבד לו הדיבור, הוא מנהל בעיקר באמצעות האינטרנט את העמותה שהקים בארצות הברית, Prize for Life, פרס לחיים קוראים לה, והיא מעניקה פרס של $1,000,000 לחוקר שהביא תוצאה משמעותית בדרך אל התרופה. ברור לו שהזמן עוזב וצריך להתקדם. הוא יושב שעות אל מול המחשב עד שהוא קורס מעייפות. כדי גם עכשיו? קבוצות מחקר בכל העולם התחרו ביניהן בשנים האחרונות על הפרס שמציעה העמותה. את $1,000,000 הראשונים קיבל לפני חודשים אחדים חוקר אמריקאי שפיתח שיטה למדידת קצב התקדמות המחלה. אז מה עושים מחר?
אז מה שעושים מחר למשל, זה דואגים לזהות איזה פרס של $1,000,000 אנחנו הולכים להציע בתחילת 2012. ומה שעושים מחר זה לראות איזה אנשים אנחנו מגייסים, ולמי שגייסנו ומה בדיוק הם הולכים לעשות.
טוב, זה תעשו מחרתיים, כי זה באמת כבר
לא, אבל זה יהיה מחר, זה בדיוק העניין. ומחרתיים יהיו דברים אחרים. אין זמן, הוא כותב. זה אולי לא הייתי מדויק, זה מה שיקרה בחצי הראשון של היום.
מר אביחי קרמר, זוכה פרס ראש הממשלה ביזמות ולחדשנות ליום מטרת רווח.
לצערי, אני יכול כבר לדבר, אך לא אתן למחלתי לקחת גם את קולי. ליאונרד ברנסטיין אמר פעם, בכדי להשיג דברים כבירים נדרשים שני דברים, תוכנית טובה ולא מספיק זמן. ההכרה שימיי קצובים שיפרה אותי כאדם. אני מוקיר כל בוקר חדש וכל רגע של יופי. אני צוחק יותר, מפרגן יותר, רואה ברור יותר כל צבע ושומע חזק יותר כל צליל. פתחתי בציטוט ורק ראוי שאסיים באחד. הפעם של ג'ורג' ברנרד שואו, שאמר, האדם ההגיוני מתאים עצמו לעולם. האדם הלא הגיוני מתעקש להתאים את העולם לעצמו. לכן כל קדמה תלויה באנשים לא הגיוניים. תודה שהקשבתם לי, אביחי קרמר הלא הגיוני.
אני רוצה לקדם את המחקר על ALS. בוא נכפיל את הכסף שמושקע במחקר. נכפיל אותו בשניים.
לא חבל שלא היה איזה אביחי לפני 20-30 שנה שכבר כל העניין היה נפטר? מחלה ידועה בערך 90 שנה, וכאילו שכלום לא נעשה. איך אף אחד לא מתעורר? חכו לבן שלי.
יודע שאני לא אמות מ-ALS, אני רוצה תהיה תרופה. גם אני, בבית שלי מביאים אותה יום קודם, אז מצוין, זה התפקיד שלנו. אבל תהיה תרופה ואני מקבל אותה. אתה תפורי.
So what I want to talk to you about is really what is the mind process of accelerating development of treatment. what is missing and what should be done to get it. Because I want you to go through this process in your mind for ALS and for other diseases. So what would attract a drug company to study a disease like ALS? If you were the CEO of a large pharmaceutical company and you could invest in researching on any disease, why would you choose one disease and not another? So profit, yeah, but what would make you think that one disease is more profitable than other? The amount of people with the disease. Okay, so the number of people with the disease. Did you say something else?
No, I was agreeing with him that
okay.
Profit should be the
main
goal. So if there are 1 in 10,000 people, 100,000 people that have the disease, then the cure obviously is not going to be a cheap one if it's ever found.
So first of all, I want to say that to generally say profit, that definitely would have to be true. So a drug company would invest in a treatment that is likely to make it to the market and then make profit in the market. So one problem is the question of what is the client base, right? How many patients have the disease at any given moment? But I want to frame it a little differently. So the way we usually think about it is not the number of patients per se, but the need, the size of the need for the treatment. For the most obvious example would be like the common cold is a disease that affects essentially half of the world population every year. But the need is smaller. So how is this need manifested? The amount of money people would pay for a treatment for the common cold is not that large, right? Because they could just handle it without any treatment. A disease like ALS would have a smaller patient base, thankfully, but the need is much larger. Yeah. So the need. How would this need be described? So. How do you calculate unmet need? So first of all, unmet need would require that there would not be a lot of treatments already available on the market, right? If a disease is well treated by treatments that are already on the market, there's not much of a need. Then there would be really the calculation of the number of patients. So how many patients would use your disease? And then the other part of the need would be how much they would be willing to pay for such a treatment. So a disease like ALS has a very high disease burden. The estimation in the United States, and this is an estimation for about 5 years ago, and I think it's increased since then, is that if a patient that is fully paralyzed due to ALS has to go into an institution, his insurance company would pay close to $500,000 a year for treating him. So an ALS patient would need at least 2 caregivers, 24 hours a day, and so on. In-home treatment is obviously cheaper, but it still is a substantial amount of money. So just to go by like a very economical standard, if this is the cost of taking care of a patient in an institution for a year, a treatment that would cost not 430, but 400 would be profitable for the insurance company to pay, because they would still save money for that patient annually. But actually, there's also what is called the emotional burden of the disease. ALS is a fatal disease. It's 100% fatal, and it's fairly rapid. So the ability of an insurance company not to provide an available treatment for its patient is essentially zero. Like this would never hold in court, that an insurance company refuses to give a life-saving treatment. So there is a balance between the number of patients and the need. So the number of patients is small, the need is very high. So in that sense, ALS is not doing that badly. So there are diseases that are more common and also have high need, but that would still be a good consideration. But so as the newly minted CEO of a large pharmaceutical company, right, you have all this money, but you have to choose to invest only in several diseases. What would be the criteria that you would like to establish to choose what to invest in?
One of the things I would check, unless one of the reasons I'm the CEO is family member who has it.
No, logical reasons.
Yeah, would mostly be that it's the amount of money and resources I would have to invest before I got to the first trial would be fairly low. So
okay, so
something that already has some research on it, that already has some base.
That's an excellent point. So very good understanding, so basic research or understanding of the disease and understanding of potential drug targets to develop drugs for. So if you have a solid understanding and you feel the drug targets are good, it's much easier to progress into clinical trials. Anything else, like within the gap between really great solid targets to a treatment that gets to the patient? What would be great to have, right? What would make you decide to invest in this disease? So let's say that this disease has good targets. Yeah. Now what is the next step?
I need either a patient base to try it on, people that are willing to volunteer, and I would also, except for basic understanding, I also need some things have a basic understanding, but you're not really sure how to approach it. Then you would want to see if maybe there's something that's already used that works in some degree.
Okay. So one thing is, I would say, translating basic research into an actual treatment. So that's definitely one thing. If you have tools to translate it, if you can take something else. And then in your point about taking something else, there is another important consideration. And that's the idea of shared mechanism. If I could invest in one disease and then also get a treatment that works for two diseases, then of course it's much better for me, right? So if I could focus on mechanisms that are shared between ALS and other diseases, that would be much more beneficial for me. Let's say ALS and dementia, I don't know. Then another point within this is that I will also have to test this on patients. So if I have good tools to test it on patients, if I have good access to patients, and so on, that would also make it easier and cheaper and more rational for me to invest in this disease. So I'm just summarizing. So you need a large need. You need a good understanding of the disease pathway for drug targets, hopefully drug targets that are relevant for more than one disease. And you need to be able to execute clinical testing of your targets as easily and as cheaply as possible. So now we're going to go kind of more in depth to this point. So we talked about the need. Now the biology. So how would you, okay, so let's imagine we're going back in time 100 years. The disease is first characterized. And you want to understand the biology of the disease. What's the first step that you do? It was already mentioned before.
Say it again.
What was the first step that you would do? So you have a new disorder that is first identified. You are the first clinician to identify it. What do you do then?
You check where the problem is.
Yeah. So you try to see if there are genetic bases for the disease, if there is familial cases. And in these familial cases, you try to identify a mutation, exactly. So the first mutation that was identified in the early 90s. And it's a mutation in a gene for a protein called SOD1, superoxide dismutase 1. It's a gene on chromosome 21st. And it's involved in various antioxidant activities. It's not very common in ALS. You see it in some of the familial cases, and you hardly ever see it in the sporadic patients. But the reason it was found first, because it's a very, very lethal mutation. So SOD1 is a dominant mutation. So if you have even one copy of the mutation, you will have ALS. And if you have a mutation, you are bound to have the disease. This is called that you have 100% penetrance. So the connection between having the mutation and having the disease is 100%. SOD1 has 100% penetrance, so all mutation carriers have ALS. And that's why it's easier to identify it, because you see these families that really half of the family is affected by ALS. So then this mutation was identified. So there's been a lot of research since then to understand the biology associated with ALS in the motor neurons. And since this is not the point of my talk, I'm only going to go over this kind of briefly, but it kind of goes like this. So the first thing that was identified is mitochondrial dysfunction. So the SOD1 gene product, the SOD1 protein, was suddenly found in the mitochondria of ALS patient. It's not naturally localized to the mitochondria, which already showed that something was difficult. Something was problematic, and you saw that the ability of these mitochondria to produce energy was then reduced. The introduction of SOD1 reduced their ability to produce energy. And this seemed very relevant because motor neurons are the largest cells in the human body, so it would make sense that they would require a lot of energy. So mitochondrial dysfunction could be very problematic for them. The second thing that was identified is the formation of toxic aggregates within the cytosol. So toxic aggregates are a hallmark of neurodegenerative diseases. The question is, what exactly are the aggregates? And that changes between diseases. So there were evidence that SOD1 is apparent in these cellular aggregates. It's apparent is in its mutation form. So the SOD1 protein, when mutated, is within itself toxic. It has a copper and a zinc unit that actually can hurt other proteins. And it's also aggregating other proteins, and through this aggregation, they lose their function, right? They're not doing what they should do. Instead, they're stuck within the aggregate. So these aggregates are toxic. They prevent the cells from functioning. And this is really something that you see in a lot of motor neurons from ALS patients. Other things that we saw, there was neuroinflammation, so evidence for activation of inflammatory process within the cell and with supporting cells, and glial toxicity, so toxicity associated with the supporting astrocytes. So if the mutation was only introduced in the supporting astrocytes, still you saw ALS. So it doesn't only have to be within the motor neuron themselves. So this is kind of a very rapid introduction to the biology of ALS, because what I want to focus on is a different point. One of the important things about identifying a mutation like SOD1 mutation in ALS is that it enables you to develop a mouse model for a disease. And a mouse model for a disease, in this case a transgenic mouse model with SOD1 mutation in it, the importance of a mouse model is that it's something you can test treatments on preclinically. So you have something that you, like an actual animal as opposed to cells, that you can test whether potential treatments for ALS work. So for a mouse model to be useful, it has to mimic the disease fairly well. So the SOD1 mouse model has one benefit, is that the clinical characteristics are actually very similar to ALS. So these mice live normally, and then at about the age of 100 days, they start to very rapidly deteriorate in motor function. They become paralyzed. They also lose weight rapidly, which is another hallmark of ALS. And within about 25 to 30 days, they die. So very rapid adult onset progression of disease, similar to what we see in ALS. So this is the good side of this animal model, that we actually see disease progression that looks similar to ALS, and then we could actually test if a treatment is effective on it. What are the downsides of this model? Like, why is it not perfect? Yes?
Well, among other things, you said 100 days they get it, 30 days they're dead. We've already established that in humans, 3 to 5 years, and also the age at which you get it. They said the average is 50, but you saw also 29, 30, and then also older.
Yeah.
So you can't even check if it's like once every 7 dog years or something like that.
Yeah, it's true. So that's a good point. But there's another also difference. So how did these mice get ALS? Yeah, we introduced a mutation for SOD1, so it's transgenic mice. SOD1 mutation is not common in actual ALS patients, neither familial nor sporadic. So this is a disease that actually captures only one type of ALS, right? And not the most common type necessarily. And that's why we also see that the mice are very homogeneous, but the ALS patients are tremendously heterogeneous, and everyone lives a different lengths of time. But the benefit of developing the mouse model was really that it enabled really this very standardized testing of drugs by drug companies and by academic researchers. And it really led to tremendous development within the drug development for ALS. So this is the timeline, right? So this is SOD1, the identification of the SOD1 mutation. And this is the introduction of the ALS SOD1 mice. This is the number of ALS treatments that were tested since the development of the ALS mouse model. These are the number of clinical trials for ALS since then. No, I think this is different genes that have been identified. Yes, I'm sorry. So, and also you saw that so many different treatments were tested since then, and also many other mutations were identified since then. So there's been really led to a tremendous rise in the amount of research being done on ALS. And this led to really a lot of trials by a lot of drug companies. Now, let's say that you already decided to invest in ALS. Now you need to decide what kind of a drug to develop for ALS. What would you focus on? Someone? Hmm? So growth factor to preserve the nerves. Yeah, that's a good suggestion. Any other suggestion? You have all this money. You need to develop drugs. What would this drug work on? Yes?
Also, I would focus on calming the symptoms as well.
So what do you mean by calming? Yeah.
Alleviate the symptoms of the disease.
So how would you calm the symptoms? How would you do it?
I don't know. Identify the cells that are being destroyed in the brain, impeding the speech ability, for instance, and find a treatment that could impede that deterioration of those cells or help regenerate those cells.
Okay.
That's an example. The same could be done for the motor symptoms and other symptoms.
Okay. So one thing is maybe regeneration, so that's similar to your point about maybe growth factors. And another point is maybe something that would stop the deterioration of the motor neurons, right? So what could be things within the cell to focus on to stop the deterioration of the motor neuron? What could be things to focus on to stop the deterioration? Yeah.
Check on the mitochondrial dysfunction.
Thank you. I'm so happy. Anyone else want to make a suggestion? So you have now like enough understanding of the disease to actually develop drugs for ALS because, bless you, because this is really what we see if you look at the landscape of drug development for ALS, we see exactly this sort of level. So some people focus on mitochondrial dysfunction. Mitochondrial dysfunction, so you can see here, this is dexpramipexole or DEX, which is actually an antibiotic, but was tested for ALS by Biogen Idec, a large American pharmaceutical company. Another drug tested for mitochondrial dysfunction was rasagiline, which is now actually being tested in a large academic trial. There's also treatment developed that try to focus on these aggregates within the cells, the toxic aggregates. So try to approach either protein misfolding, for example, developing of an antisense treatment for the SOD1 mutation to specifically silence this mutation or to develop an antibody for the different mutations. You could see that some people decided to focus on the inflammation. So I said there are signs for neuroinflammation. So maybe look at different modulator of the immune system and their effect on ALS. Also problems up there, problems associated with glial toxicity. And there's also people that try to look at regeneration in general through growth factors or through other things. And there's also treatment that try to completely ignore the biology of ALS and focus on correcting the symptoms. For example, this treatment by cytokinetics that doesn't look at the motor neurons at all, but look at the muscles and tries to reduce the threshold of muscle activation. So the idea is that the less motor neurons you have, the less you're able to activate the muscles. If you reduce the threshold for muscle activation, you compensate for the loss of motor neurons in ALS. At some point at the end, there would be no motor neurons, so there would be no compensation, but that should delay this process by somewhat. Another approach to compensate is through stem cells. So what if you inject stem cells, either to replace the motor neurons by iPSC-derived motor neurons from a donor, from an external source, or you could use autologous delivery of stem cells and really use it as a delivery mechanism. So then you would have that, they would integrate into the motor neuron network and secrete various growth factors. So you see that really all of these approaches are being tried by different companies. Every CEO has their own pet pathway, so different pathways by different companies. And still, we don't have a treatment right now for ALS. So while there have been a lot of ALS clinical trials, they all failed so far. So none of them have actually been effective, found to be effective in humans. So why? So we see these treatments. They have been developed in the lab. They have been tested successfully on the SOD1 mouse model. They have been tested in humans. And then they failed. Why? Okay, so I'm trying to put the many correct answers that you had into several categories. So one, it could be that it wasn't effective in the lab even. It was just a mistake. That's definitely possible. Option number two, it could be that it was effective, but effective in the lab, but not specific enough for humans. Anything else? This is the two broad categories. Maybe I missed.
One of them was that when it left the lab, some medication, when it reaches its target immediately, it's fine, but sometimes it gets contaminated from other medication or
I see. Okay.
non-intravenously through the.
That's an excellent point. So maybe interaction between the medication or just metabolic processes that we didn't see in the lab. That's an excellent point. So I have slides about the other points, but I want to first mention something that I don't have a slide for your first point. And what if it wasn't effective in the lab at all? What if it was just a mistake? So how many experiments that are done in the lab are reproducible in general, unrelated to ALS? Anyone wants to suggest a percentage? Pick a number.
5.
So higher than 5.
10.
Higher than 10, but you're warming up. Approximately 20 to 30. Yeah. So actually, most of the experiments are not reproducible. And there's a really terrible cautionary tale about this in ALS. So there's a drug, a psychiatric drug for bipolar disorder called lithium. Lithium is a drug. It's been on the market for many years. Relative for a psychiatric disorder, it has pretty mild side effects. And for various reasons, it was tested in the ALS mouse model for ALS and was found to be tremendously effective. It increased lifespan by about 30%. Now, lithium is a drug that one can buy in the pharmacy right now, and a neurologist can prescribe it right now. This is what is called an off-label medication, meaning that if a neurologist prescribes it to an ALS patient and not a bipolar patient, so the bipolar patient has the label, so for bipolar, and an off-label is if you give it to someone with another disease. So ALS patient heard about this very successful experiment, and they went to their neurologist and asked for a prescription for lithium. And as many neurologists noted, they might say no, but certainly someone would say yes, right? Someone would give them a prescription for lithium. So it became something that thousands and thousands of patients were using, despite the fact that it was actually never tested in a clinical trial. So there's been some outcry about these tremendous number of patients that are taking something that was never tested. And several ALS nonprofits and also governmental grant decided to have a clinical trial on lithium for ALS. This clinical trial cost over $100 million and lasted for a while. During this time, the patients are still taking it, and it has some side effects still. And it was found to completely be ineffective. And not only was it found to be completely ineffective in patients, it wasn't even reproducible in a mouse. So a lot of patients took it. They had all sorts of issues with it, but it was not found to be effective in them. So yes, sometimes the problem is just that what we do in the lab is not reproducible. But let's assume that it is reproducible, just because I want to focus on the path between preclinical study and clinical study. So in this gap between what we see in the lab and what we see in patients, a lot of things need to happen correctly. So we need to develop it in certain dosage that fit with humans as opposed to animals, and fit with human metabolism and not animal metabolism, and would stay in the system long enough to have an effect, yet are not toxic. And then this all needs to be formulated and tested in ALS patients, so we also need to recruit ALS patients accurately, a large enough study, accurately recruit them, accurately balance them between placebo and treatment. And I want to give you another two examples. So you mentioned growth factors. Growth factors were huge in the early 2000s for ALS and for other neurodegenerative diseases. And there have been a lot of studies on growth factors for ALS. You could see here, so different growth factors, how they were delivered, and what were the effect on the ALS mouse model. And some of them were really tremendous effects. Like you see here, this really, like for a mouse, a 33 days increase in survival. That's like his entire disease progression doubled. So these really substantial effects. However, all of these different drugs were tested in humans, and none of them succeeded. Why? There are some clues in this table. Maybe you see in it some things that might not be immediately translatable to humans. Yeah? What did you say?
Yeah, the delay in onset. You can, by the time the patient comes, the disease is
That's exactly, yeah. You're the first one who got it as the first point. So, wow. You see one thing in this table. You see that, for example, if you give IGF-1, you get a delay in disease onset, a very substantial delay in disease onset. You also see it for many other things here, like GDNF leads to this delay in onset, and several other growth factors lead to delay in onset. which means that they were giving it to the mouse before disease onset, and that's why they could test the effect on disease onset. However, in a disease that affects 1 in 1,000 patients, it's not realistic that anyone would get any disease before disease onset. And I would say not even disease onset, because they need to be diagnosed. So it's not even onset, it's diagnosis, and there's a gap between the two of them. So one problem is we're testing all of this with mice from a much younger age than we would ever have access in patients. Maybe growth factor would have been effective if we gave them early enough in the disease, but by the time the patient gets diagnosed, he's already beyond repair. So that's one option. Any other things that you see here? There's several other things. Just pick weird words here, like weird things that you wouldn't like happening to you. Where? Oh, yeah.
Down there.
Decreased loss of motor neurons, yeah? Well, that's good, because they don't lose as many motor neurons as before, so that's nice. Yeah. So let me suggest one. There's more than one. For example, let's take the best one, right? This one. So you see this delay in onset, but the increase in survival is 37 days. 37 days for mice is really a tremendous amount of time. But how does this number translate into humans? What if the number in human would also be 37 days? Do they really need to get injected by growth factors chronically for these 37 days increase in survival? And we don't know how it scales up to humans. We don't have good models for how growth factors would scale up in humans. Another thing is, how would that even get to the humans? So in this case, you see mostly injection to the muscles. Some cases you see here injection to the stomach, or injection subcutaneously, so under the skin. The muscles in humans are slightly larger than the muscles in mice. The ability for a treatment to actually get to the motor neuron from the muscles in a human is much lower, right? So the medication is the same medication. Its ability to diffuse all the way to the motor neuron is much lower. So we don't even know if it scales up physically to human size. And if you want to inject it more directly into, let's say, the spinal cord, then that's a very difficult treatment. So if you want to do spinal taps on a chronic base, that's already something to consider as a difficulty for this treatment. What if you hurt the patient? Several reasons why these failed in humans. So one difference is just that they were all tested on the SOD1 mouse. And maybe the SOD1 mouse has its own mechanisms that these treatments affected. But we don't see it in humans that have all sorts of mutations or no known mutations at all. It could be also that the choice of the growth factors or the neurotrophic factors was wrong, because humans and mice don't have the same neurotrophic factors. It could be that the mode of delivery was very limiting. As I said, delivery to the muscles, not really that great. And it could be that the duration of action just didn't scale up at all. Like the duration of of action was too similar to what we see in mice. I'm going to go to a second example, and that's a harder example. So these are two medications that were in the list before, ceftriaxone and dexpermethexol. So ceftriaxone and dexpermethexol actually were in an even more difficult situation. So both of them were tested in mice. So the preclinical testing was great. Then they were tested in humans. So the way you do clinical trials in humans is you do 3 phases. The phase 1 clinical trial is a safety trial in which you just want to make sure before you progress with this drug that it's actually safe to give it to humans. It's usually a small trial just to show that there aren't critical adverse events. Then you progress to the phase 2. Phase 2 is focused on the efficacy of the drug, so the ability to actually have an impact on the disease, but it's a small trial. And the idea is that you take a small number of patients and you show some efficacy, and if you are able to show some efficacy, you progress to the last phase, phase 3, which is like the full-scale study. So it's large, it usually have hundreds or even thousands of patients, and this is what the results on these patients are what will determine that the drug will actually get approved and make it to patients. So both ceftriaxone and dexpramipexole were tested in mice, and they went through phase 1 and they were found to be safe, and they went to phase 2 and they were found to be effective in phase 2, and then they went into phase 3. So this is dex. This is the difference in effectiveness of different dosage of dex in the phase 2 trial. So you see it wasn't only effective, it was effective in a dose-dependent manner. So the higher the dose, the higher the effectiveness, which is what you want to see. Then this is the comparison between placebo and treatment in the phase 3. So it doesn't look so good, yeah? I mean, it's tremendously similar in effectiveness. So we really didn't have even a weak effect on the patients. The next example is the ceftriaxone. So this is the phase 2. The yellow is what you see here. These are placebo patients. So this is how they would progress without any treatment. This is over weeks. And the blue and red lines are what you see for people that were treated with ceftriaxone, either 2 grams a day or 4 grams a day. And you see that they are more stable, and as time passes by, the differences between the treatment and the placebo group only grows bigger and bigger. So this looks quite promising. And then we went into phase 3, and in the phase 3, I think they had about 700 patients, and this was the difference between placebo and treatment. Almost nothing. In case this is really like the last thing you want to see, right? Like it didn't even have a mild effect. So what happened?
It works on statistics. So the larger group, you have a better correlation, and it's more predictive. Smaller group, it could be small things. Someone trying something else. Somebody who has specific different biology stuff. Again, the way he reacts to the medication. So over 70 patients, it could be very good because you have one person who reacted very well to the medication, and most of them did not. And then phase 3, because most people do not react positively.
Exactly. That was exactly the point. I'm going to rephrase it and say it loudly, I hope. But exactly that was the point. So the reason why we do phase 2 clinical trials is to test if something is effective in a small group. And the reason why we do phase 3 trials is because a small group is not enough. Statistically speaking, you need a large enough group of patients in order to see that something is effective. And when you only look at a small group of patients, you're very, very much dependent on the very small individual differences. So let's say if you had like, I don't know, if you had Stephen Hawking, it would never even made it to a phase. In the placebo group, it never would have made it into phase 3 because it would have looked so much better just because of the presence of one additional patient. The numbers are so small that every specific patient is tremendously influential. So then if you happen to have slow progressing patients in one group and not the other, this will tremendously affect your trial. So you could see it here for a treatment that was found to be effective, although it was not. But it could actually also be the other way around, right? what if a patient would, what if a treatment that is really effective would fail a phase 2 clinical trial because it was only given to 40 patients, and in these 40 patients, they happen to have very slow progressing patient in the placebo group. That treatment would never make it into phase 3 and would never actually make it to patients. So the heterogeneity of the different patients really influenced the results here. And you could see it here in the confidence. I mean, look at this bar. There have been some patients that have been doing very well, and there have been some patients that really have been doing the same as the placebo group. So already in this tremendous variability, you see that you don't actually know how the treatment is really affecting the patients. They're too variable to tell you anything meaningful. So what can we do to improve this? What do we have to do to improve this? More carefully design the trial. Yeah. How? Then you're right. Yeah.
Patients show up after they've been diagnosed, after they have gone through the disease for a while. Check if they're slow progressing or not.
That's excellent. So 1 point. What's your name? Well, Tamal? So 1 point from Tamal is to really do a more thorough analysis of the patient profile before they enter the trial here. So to really understand how they're progressing and maybe other factors about them before they enter the trial, and then balance the trial better. So be careful to put in different treatment groups patients that are as similar to the other treatment groups as possible. So you don't clump together all the fast ones versus all the slow ones. This is definitely a very, very important point. Is there anything else that we could look at these patients before they enter the clinical trial? I'm looking at you because I know you know.
Said it already twice. You need to check their genetics.
Very good, thank you. So maybe we could have a better genetic understanding of the patients before they enter the clinical trial. So at least we know what is the differences between them. Bless you. So one other thing, let me note this. So I didn't say what was tested in this trial, so I'm going to say this now. What was measured was ALS-FRS. ALS-FRS, ALS Functional Rating Scale, is the primary measure for disease progression, the primary outcome measure for clinical trials. And this is really a questionnaire that a clinician fills out with the patient in his office. And it goes something like this. How well can you walk from 0 to 4, 4 being normal and 0 being completely unable to? So how well can you walk? How well can you speak? How well can you swallow food? How well can you climb stairs? 12 questions about daily functions. And the final score in this is a score between 0 to 48, 48 being normal in everything, and 0 being completely unable in all of the different questions. And you see here, for example, that the patient entered at about 35 on average. So we're about, right, 75% able. And they deteriorated over time so that the placebo group really reached like less than 10. So they were mostly unable in most functions. Do you think that there might be problems with developing a drug that would cost about $1 billion to develop and then having it completely rely on this questionnaire? What could be the problem with this questionnaire? Yes?
I don't think they need to ask the patient themselves. They just need to see how they function.
But not
especially if they have $1 billion to do it.
So it would be good if it would have been a more objective measure of disease function. So not always do they have access to that, right? Because they only see the patient for like about half an hour. So they don't they're limited in what they can ask him to do. So obvious things they do ask, like to speak. But let's say one of the questions is, how well can you dress yourself? Dressing and hygiene. They don't ask, they just ask. But this is a very important point because we see differences, consistent difference between patients and caregivers. The patients always rank themselves better than the caregiver does, for obvious reasons. And especially when they enter a clinical trial. So this is like, there's always placebo effect in all clinical trials, but if the placebo effect is dependent on subjective measures, everyone feels that they are doing better. And you could even see it here to some extent. So look at what a slow progression the placebo group had in the beginning of the trial. They really felt that they were improving. As time went by, this effect dissipated, which is something that we typically see in a placebo effect, that it doesn't last forever. But in the beginning, they really felt like their disease was being more stable, they weren't deteriorating as much, and in a subjective questionnaire, that would be very effective. Even, I have to say, even if there wasn't a placebo effect, it's also how the clinician would ask this question, right? So how exactly do they frame it? What do they call 3? What do they call 2? What do they call 1? So they're defined. So there are definitions, but they're open to negotiation, let's say. So the definitions would be something like, I walk normally, so that would be 4. I need assistance in walking. I can only walk with a permanent assistant, or I am only able to do ambulatory movements, or unable to move at all. So you see the 3 and 2 are a matter of perspective. So maybe the patient feels that he could have sometimes managed without assistance, but he actually have not managed without assistance for a while now, and he's ignoring that. Or the opposite way around. Maybe he feels that he's tremendously dependent, but in fact he's doing okay. So it depends on this subjective score. So what would be good to have instead of the subjective score? So one option is to objectively look at their clinical capacity. Anything else that would be really great, right? Exactly. What if we don't need to look at the clinical manifestation, but we actually have something that tells us about the real biological progression of the disease? So that would be a biomarker. If we could have a good objective biomarker for the disease, a blood test, maybe a spinal tap test, so a CSF test, we could use that and actually track disease progression, which is what the medication is affecting directly, as opposed to walking or cutting with utensils, which is a much higher level function. So it would be great if we had a biomarker. It would be great if we had a much better detail of the clinical phenotype of the patients. And it would be really great if we had what is called stratification of patients. What is stratification of patients? Meaning that we would be able to identify subgroups within the patient population. So we wouldn't say all patients are the same, we would find subgroups within them. So if we could say that, then we could say, well, here we had 3 patients from this group that, let's say, had this mutation, and we also know that they're very slow progression. And here we had 10 from this group that are known to be very fast progressors and so on. Then we would have a much better understanding what we're seeing. And given the heterogeneity of the ALS patients, it's obvious that they are subgroups within the patient population. So if we'll be able to extract them and treat them differently, as opposed to group them all together as one group, we would have a much better understanding of what is happening in this patient and whether a treatment is effective for them. So just as an example for the heterogeneity, so this is a simulation of a clinical trial. Let's say that you really have, so this is a hypothetical medication that improves survival by 30%. What do you need to do with this level of variability, what do you need to do in order to be sure that you would see that you would see the effect and you wouldn't lose it? And the answer is that for that, you would need 350 patients. And if you didn't have 350 patients, you actually don't know if what you're seeing is true or not. Another point that would be great is if we could get the patients into clinical trial faster. So either faster after they were diagnosed, but ideally also to shorten the time between disease onset and diagnosis to get the patients from symptom onset into clinical trials as soon as possible, because maybe the treatments are working, but for these patients, they already don't have any motor neurons left to affect. So they're beyond help, but if we had gotten them younger in their disease process, they would have improved. And for that, I have the slide here. So on average, it takes, in the United States, it takes ALS patients about a year between disease onset and diagnosis. So disease onset usually starts with very, very stereotypical symptoms like weakness in the fingers of the left hand. So, I mean, what do you do if you have weakness in the fingers of the left hand? Which doctor do you go to? Well, you go to the primary care physician. But which doctor does he send you to? A hand doctor, an orthopedic doctor, maybe a general neurologist, depending on your symptoms. I have to say that now that I know a lot of Israeli ALS patients, you cannot imagine the kind of weird places that they go. They really, like maybe they could do a knee surgery, all sorts of weird stuff, until they even make it to the ALS clinic to be observed by an ALS specialist. That could take a year. So it depends how much it depends on their age. Typically younger patients go to see the doctor faster, are more disturbed about weakness in a limb. But this can take a long time. And maybe this has affected our ability to improve the status of these patients.
I have a general question. Can I?
Of course.
There is like patients who live much longer. For example, Stephen Hawking living until today.
No,
like
he's
4 years.
52 maybe, yeah. He's doing, yeah.
Okay, so why not check his biology, like how he lived for so long?
So he doesn't have any known mutation. But I have to say that he participated in many times. He's like a ALS celebrity, right? So he doesn't have any known mutation. Essentially, he's in a status that he doesn't have anything that would differentiate him. So what we need is better tools for research, maybe, better tools to understand what differentiates the patients. And then we could say, what is it about Stephen Hawking? It's not something that is obvious. I'll put it this way. Maybe it could be something...
during the entire time of his disease. So.
Maybe, but of course, genetic is complex, right? So I'm saying that it doesn't have any known mutation. It could have a combination of mutations, right?
Is it possible he doesn't have ALS? Or something else?
It's possible that if we had better stratification of patients, we would find that one group is so different that they should get their own name.
I went to an article that said even Lou Gehrig didn't have ALS.
But what did he have?
He had a different disease. I mean, it's hard to, isn't it hard to tell? Like,
so there is not a lot of diseases that look super similar to ALS. But it could be that within ALS, there are several diseases, yes. It could be that Lou Gehrig and Stephen Hawking shouldn't be under the same umbrella, yeah. But we don't, so if we had a better understanding of how different patients look like over time, then maybe we would say, yeah, what Lou Gehrig has should really get a different name completely. Maybe what Stephen Hawking has should be called, I don't know, long surviving motor neurons or some other name. So that could definitely be. For that, we need a much better understanding of even the clinical profile of the disease. So what happens before they die at 2 years, or not die at all, but at least we've been living for 50-something years. like what else is happening? Because if we only know survival, then it's not, it's too late, right? Yeah. So I'm going to try to talk, and then there's also other options. And that's, so we talked about the different time frames. So maybe treatments would be effective if given very early, for very early patients, but are no longer effective for very late stage patients. Maybe different treatments should be given to late stage patients. Another thing is really the idea of a cocktail therapy. What if every treatment, so you saw that there are different targets, right? So what if every target does have an effect, but not a very large effect? So what we need is a cocktail of therapies, each affecting different pathway that is involved in the disease. And then, of course, maybe different ALS patients actually would benefit from different treatments. So in the cephaloxime, in the DEX group, so you don't see the chart, but in here, so you see that overall there wasn't any difference between the treatment and the placebo group, right? They were almost completely identical. But there are still patients that feel that they were in the treatment group and they were benefited by DEX and are still requesting to continue to use it. What if they're right? What if there is a subgroup of responders for which the treatment is effective, but they are masked by the overall statistics? So what if we can find subgroups that are effective? Now, I don't have a lot of time, but I want to go over very, very, very shortly on potential ways to help overcome these problems, or the ways we think about overcoming this problem. So we try to look at the barriers, and we discuss the barriers. So one barrier is the biomarker. So to have an objective, hopefully biological marker that can really tell you how the disease is progressing and how your drug is affecting this disease progression. So we had a workshop with a representative from industry and academia, and that's what they highlight as the biggest need. So the biggest need is if they could actually see if a treatment is effective. Without that, it's very hard to work. So the biggest barrier would be a biomarker. And then the first thing that Prize for Life did, the first thing that Avi started when he started Prize for Life, was the biomarker prize. So a prize, $1 million prize, to whoever will develop a biomarker that can really predict disease progression. And the idea is that one would only get $1 million if he will develop a biomarker that is specific enough to be used in clinical trials. And this challenge, this prize, was ran for about 4 years. And eventually it had a winner. And the winner, I don't think I have a slide about it, and I don't have time either, but the winner was actually not what we thought it was, which is interesting. So we were hoping for a blood test, maybe a CSF test that would really be able to very, very well chronicle the disease progression. None of the submissions was able to do it well enough. But one clinician submitted a proposal for a biomarker that tests muscles directly, so muscle volume. And his logic was that, of course, as the disease progresses and the muscle atrophies, so no more motor neurons, the muscle atrophy and die. Muscle volume can actually be assessed directly with a very high level of precision. So his logic was to go body part by body part and assess muscle volume, and that would be your most precise level of disease progression. And he developed this biomarker, so it's a medical device, and it's now being used in several clinical trials. The next thing was really to improve the mouse models, right? So we see that not everything that works in a mouse model ends up working in a clinical trial. So what can we do about this? So the second program was the treatment prize. So to submit your results from working on a treatment and testing it in mice, preclinical testing. But the requirement was like this. First, we gave them the mice, so that we were able to see that the mice are actually very, according to the highest standards. And they had to make sure that the mice studies are also according to the highest standards. maybe I have it? Yeah. So they balance gender of the mice, all sorts of things. They balance leader mate of the mice. So they actually do the mice work at least as accurately as possible. So we don't just see these unreproducible studies. And we took it upon ourselves that if there is a potential winner, we're at this state now, we will reproduce the study ourselves. And they will only get the prize if the study is reproducible. The third point was really to understand the disease progression well, and what we talked about with stratification. And then our last program was to really look at disease progression and develop a prize which is more a computational prize. So to people to use clinical data, and using this clinical data to differentiate the different patients. So we had one prize for prediction of disease progression and another one for stratification. And I think I really ran out of time. So I'm just going to send a note. So Avi Kramer, who started Prize for Life and lives in Haifa. So people ask me sometimes, so he is very much alive, and he has ALS for 11 years now. But he had gotten to the point that he feels like he cannot be a full-time CEO of an organization. So he brought with him another ALS patient from Israel called Shai. And Shai wanted to really say, like, that victory is a way of life. Like, you don't have to get all the way to a treatment. You just have to improve the path for a treatment. If you did something that other people could build on, then you are part of the victory over ALS. And he asked me specifically that I would convey this message to you, so you too could be part of the victory over ALS. Everyone with whatever you do. So thank you very much.